My name's Kate Wakelin. I'm the NET Patient Support Nurse with the Unicorn Foundation, and we're really so pleased to have you here, and also just wanted to say up front many thanks to Cancer Council South Australia, who are working with us to collaborate in delivering this forum this evening. So also wanted to acknowledge that the land that we're meeting on this evening is the traditional lands of the Kaurna people. I do want to pay respects to their spiritual relationship with their country, and we also acknowledge that the Kaurna people are the traditional custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. So thank you. The other thing I'd just like to say before we get started, the information that we're presenting tonight is general in nature only, and for your own individual care, it's really important for you to talk to your own healthcare provider. So if we can just bear that in mind, both in you listening to the presentations from our speakers this evening, but we're going to have a questions and answers panel towards the end of the evening too, and you're welcome to ask. We invite you to ask your juiciest and meatiest questions to our panel, but please know that they won't be giving you individual treatment advice for your situation. So without any further ado, I'd like to introduce Professor Tim Price, who we're very grateful to have here this evening. So Tim's a Senior Consultant Medical Oncologist and Director of Medical Oncology and Clinical Cancer Research at the Queen Elizabeth Hospital in Adelaide. Tim's major interest is in treatment of patients with gastrointestinal cancer, and is currently involved in an extensive gastrointestinal clinical trial program. So he's Professor at the University of Adelaide and colorectal cancer stream leader for the South Australian Health and Medical Research Institute, and leads the Gastrointestinal Translational and Laboratory Research Laboratory at the Basil Hetzel Institute. He also chairs the current National NH and MRC Cancer Council Colorectal Guidelines Committee, which led to the recently published update. And he's also a visiting honorary professor at the University of Sydney and the University of Antwerp. And just because Tim didn't have enough things to do, he's also recently joined the Clinical Oncology Society of Australia National NeuroEndocrine Tumour Special Interest Group Executive. So we're so pleased that Tim has made a gap in his really busy schedule to talk to us this evening, and I'll let Tim come up and I'm going to find his presentation.
So thank you very much. So thank you to Unicorn and Cancer Council for putting this on, obviously. I try and hopefully keep the talk fairly short and very broad, because I think the panel opportunity is really the key, so you can ask questions. But I was asked to just talk about medical oncology because I'm obviously a medical oncologist, and so I'll just touch on a few things, as I say, very broadly. So what I wanted to just sort of cover, I guess, and I'm sure a lot of you probably already know this because of your maybe discussions and so forth, but neuroendocrine tumours is a very broad disease. It's not just one thing, and that's often sometimes hard to grapple with. I guess I'll just talk about what we aim to do when we see you as clinicians, because sometimes again that's a little bit complicated going through the various different aspects, and then just I guess touch on a few changes that have occurred in recent time. But then I think the key thing is really to have that opportunity to ask questions later. So I put this slide up really just to highlight to you that neuroendocrine tumours can come from a lot of different parts of the body, and that essentially leads to some of the complexity around when we discuss treatments, the sort of functional, what we refer to as functional component of the neuroendocrine tumours, and it's partly based on where they come from. So they can be anywhere through the gut system, particularly those that come from the so-called small bowel, lead to production of various sort of chemicals, and it's always hard to know what to describe them as hormones or chemicals. But those are the things that sort of lead to some of the symptoms. The pancreas is another common area, the appendix, and there are some rare places as well, including the gallbladder and the ovary. So it's really very broad in terms of where these tumours can arise, and then with that some of the different sort of outcomes and symptoms that can occur. And sometimes, as I say, it's difficult to describe that because we always think about breast cancer coming from one place or bowel cancer. Here we have a whole group of different sort of primary sites, and that can be particularly a problem when someone comes along with a lump or a bump, and then we have to try to find where it is, and there's lots of different places. So it's a very broad disease in terms of what it involves. So what are our aims once we have that sort of diagnosis? So I guess it is a tumour. It does have the potential to grow, and obviously one of our key aims is to really control that growth or stop it. The other key aspect, which is a little bit unusual for neuroendocrine tumours, of course, compared to other cancers, is those symptoms that patients can, and I'm sure you're aware of them, or some of you, that can get from those hormones that are released. So those so-called symptoms or syndromes that can occur. So we want to control those symptoms. There's the classic sort of group of symptoms that we call the syndromes, but there's also these very vague ones as well, which I think are often quite complex and probably somewhat sort of not understood even by the clinicians sometimes, because they're very, very subtle. I just put up there that we're not always trying to control the chromogranin A. So some of you may have or know of colleagues or patients who have, or friends and family who have this chromogranin A. I call it the Hobart test. But I think it is important just to highlight that we don't always necessarily focus on the control of that. It's a very, from my perspective, can be a very unreliable test. It fluctuates a lot. We talk about it a lot, but I think it's important not to get too focused on the chromogranin A. And then the other thing that is important to sort of highlight is how we assess those aims. So again, a lot of standard sort of approach would be a CT scan or an X-ray. Patients will talk about what the measurements are. So we do measure things, but the other complexity for neuroendocrine tumours is really around the other aspects of it. So this function, we talk about the functional component of neuroendocrine tumours. So that's where the gallium PET scan is important. So that's telling us about the function at the cellular level sometimes, or those chemical release, the cells that release the chemicals. And then there's also the biology and the grade. So we may do what I refer to as a metabolism or sugar-based scan, which is the FDG PET scan. So two types of PET scans, CT scan, and then we often also do the blood test, and sometimes we send you off for a urine test as well, amongst other tests obviously. But these are sort of the crucial aspects of how we assess the outcomes. So sometimes I think I would imagine hard to understand why you're having 3 scans. Why am I having a CT, 2 types of PETs, what's that actually doing? So it's telling us different bits of information about the actual tumour activity. In terms of the symptoms, they are obviously quite problematic for some patients, in particular the flushing and the diarrhoea. But they're not the only symptoms. They're the ones that are classically presented. People read about them, hear about them as the carcinoid syndrome, if you like, which was the classic sort of description of symptoms you might get from neuroendocrine tumours. But they're also more widespread. And I just put this up to highlight a couple. So this sort of cognitive impairment. So a lot of, certainly my patients have this subtle sort of memory sort of changes. I mean, it is a real thing and relates to the disease. And then there are some rare things such as rashes. So this pellagra is a type of rash that can occur again as a result of the carcinoid syndrome. So it's not just flushing and diarrhoea, they're key ones, but they can also be very subtle and very important for us to understand and try to manage. And the other thing I think sometimes, again, is somewhat difficult to describe is really why we use some of the drugs we use. So these sort of somatostatin analogues, they're the drugs, sandostatin, lanreotide. They were initially aimed at symptom control, but I'll touch on what else in a second. But the reason they work are these receptors. So what we're talking about are these sort of proteins or receptors on the surface of the tumour cell. And it's because of those particular receptors that the agents themselves work. The octreotide or the sandostatin or the lanreotide bind to these receptors and therefore prevent some of the both growth and also the secretion or release of those chemicals or hormones. So that's the the peculiar or specific or key component of neuroendocrine tumour cells as to why they respond to these particular drugs. And they're also important in terms of the scanning as well, which Dr. Chekik will touch on later. So we know because of those receptors, one of the key treatments that we use are what are called the somatostatin analogues, or SSAs. You'll know them as lanreotide or sandostatin. They're the two main drugs that we use. They've been used to help symptoms for nearly, well, over 20 years in fact. So they were mainly designed to help the syndrome or the symptoms. And then more recently, we now know that they also slow or stop the tumour growth. So they also have now a very broad impact in terms of our treatment. And very, very commonly used. I guess in terms of changes, so for anyone who has these treatments, they'd be aware of the fact that it's a monthly injection. That can be a hassle, annoyance, and not comfortable. So I guess one of the main changes is the delivery. So both companies that provide these drugs are trying to simplify the delivery. I guess the major change that's occurred in the last sort of 3 months is the lanreotide preparation, which is now a pre-filled syringe, much easier to give. And in fact, one of the aims was that if individuals felt they could actually give the treatment themselves. So it really frees up, the ability to get away from the health system in a way and potentially become a little bit more independent, travel and so forth. Not everyone's happy to do that, but at least it gives the option. But it's also simpler to give even in the clinic if that's where you're having the treatment. So I just wanted to touch on then what if they don't work, because that is really one of the main first-line therapies. Again, Dr. Chekik Gabby Chekik will touch on the lutate, the radiopeptide therapy. There are systemic treatments that we can consider, and I'm not going to go into detail of those. Perhaps you can ask questions. You can change the dose of the lanreotide or the sandostatin. But I guess one of the recent sort of steps forward, if you like, is this drug called trileriotristat, which is very difficult to say. But that's essentially to try to control symptoms. So these lutate systemic therapy, of course, is to try to help stop slow growth. But this is a drug that's essentially for symptoms. Now, this is currently available via an access scheme. It hopefully will be on the PBS, but it's not currently on the PBS, so I should stress it's not readily available, but it can be accessed at the moment via a scheme. So this is just a cartoon I put up really just to highlight how this drug works. So this is very much for patients who have the syndrome, so they have flushing or diarrhea or those sort of symptoms. And this relates to, so serotonin is the key chemical, if you like, that leads to the syndrome. So that's released via the tumour cells, via the sort of key metabolism steps, of which there are what are called enzymes. And we can block those enzymes, which then stop the production, which then we measure in the urine. So as I said before, some of you may have had the 24-hour urine, which I'm sure is somewhat sort of annoying and frustrating, but that's what we're measuring, is the serotonin products, and that's what leads to the syndrome. And what we aim to do is to try to reduce that. So the somatostatin, the lanreotide and so forth is aimed at reducing this, but this is now another way, by blocking this enzyme, of reducing that. Now this is actually not necessarily a new drug. So this is a version of it which was actually published in 1967. And the problem was that it did help the syndrome, but it made people feel very, very crazy, very unwell. So unfortunately, it obviously took quite some time to then improve it. So this is the drug now. So this is trileriotristat. This is a US web page. So I'm in control, control of those symptoms. It's a tablet, so that's important to note. So it's not an injection, which I guess is a plus, and works on those enzymes. And this, I put this up really just to show you what the evidence is, if you like. It's a nice graph. I think it's reasonably understandable. So this is a patient-reported outcome around diarrhea. So this was the trial. So this black line is patients who were not on the drug. So you can see this typical what's called placebo effect. So some patients did have some improvement in bowel function, even with nothing, so sugar. But you can see this drop off in terms of bowel function or bowel frequency with the drug. So this really was the proof of principle, which has led to the drug being available. And this study was interesting in that it was 12 weeks And then the patients who were on the placebo were given the opportunity to go on the drug, and you can see they also had the same effect. So really quite nice, showing that it does have an impact on symptoms. Not for everyone, but for a certain proportion of patients. And then just to sort of finish off is around trials. So the Rose Bengal study, which some of you may be aware of, is the study we're doing at the Queen Elizabeth. Rose Bengal was initially a dye. It was certainly when I was a junior, it was used to sort of look in the eye for eye injuries. That's the sort of thing it's sort of used for. But interestingly, it was found that if you injected it into melanoma, so the background to this is mainly from melanoma, where patients can get lesions on their arms or legs, multiple spots. If you inject one of those, that lesion can go away, but importantly, some of the others will go away as well. So you get this sort of what's called a bystander effect, or probably an immune response. So it's probably turning on the immune system in some way. And so this really illustrates that you inject, so the way this is given in our study is that this is injected into the liver, so not obviously lesions like in melanoma, but injected into the liver. You essentially get a direct effect on the actual spot in the liver, so that dies because of the irritation in a way of the actual dye. But you then get this secondary response, or the aim is to get a secondary response to some of the other tumour lesions beyond the one injected. So I just put this up just to show you what that means. So this is a liver. This is not the patient, by the way, that's the radiologist or the technician. The patient's name is not here as far as I know. And so this is an abnormal liver. This is the Rose Bengal. You can see it's retained. And what is important to see, I guess, is that this is the gallium scan. So you can see where that was injected, that's responded. It's gone away, that's not bright anymore. This is the functional scan. And I think you can appreciate, so you actually start from the bottom up. You can sort of see that the functional activity, which is represented by the dark spots, has decreased over time. So it's not just that spot that's responded. So this patient did very well. They were in fact in the paper. Some of you may have seen this. He was very pleased. He was reasonably unwell prior to the treatment, and he's responded very well and still doing very well. The other key thing about this patient is one of the other hidden parts of the syndrome or the chemical release is that it can affect the heart. So one of his issues around the time of this treatment was he was also getting heart failure because of his valves. And he ended up having, this is just some heart valves, but he actually had 3 heart valves replaced and then responded incredibly well to that and got back to independence. And that's about 2.5 years ago, and he remains very well. So really crucial around sort of hidden problems as well that can come from the syndrome. So I'll stop there, and as I say, I think the key thing will be to then have questions at the panel. So thank you.